Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit Podcast. Welcome back to the Med Edit Podcast. I, of course, am one of your hosts, Dr. Jessica Gray. I'm here in studio with Dr. Cari Sorrell.
Hello again, and hello to all of our TME listeners. We have a fantastic episode that has been in the work for many months that we are very happy to debut during Mental Health Awareness Month.
Today, we take a deep dive into a topic often forgotten about, a topic often women are ashamed to discuss, a topic society simply glosses over. We are talking about the most common complication of pregnancy, and it is not what you think.
I mean, let's face it, being a woman is really hard. It's very difficult for many reasons. We work really hard as wives, mothers, sisters, friends, and our profession. But certain times in life feel like that they should only be sunshine and rainbows can really sometimes be the most difficult.
Today, we are talking about postpartum depression. Well, to be more exact, we're actually talking specifically about perinatal mood and anxiety disorders, which covers conditions occurring both during and after pregnancy and includes things like commonly discussed postpartum depression, postpartum anxiety, postpartum OCD, which maybe people don't even know about.
I sure didn't before today. Today we are have our guest, Dr. Sarah Wakefield, and to say that she's an expert in maternal mental health would be an understatement. We will get her advice on recognizing the signs of mood and anxiety disorders, as well as practical steps you can take to help either yourself or your loved ones who might be struggling.
This is definitely an episode you do not want to miss.
So let's jump right in.
Today, we are joined by Department Chair for Psychiatry at the Texas Tech Health Sciences Center School of Medicine, Dr. Sarah Wakefield. She is a fellowship trained in child and adolescent and forensic psychiatry. She has a special interest in perinatal psychiatry and women's mental health. Like us, she believes in a patient-focused, multidisciplinary approach utilizing the latest technology and evidence-based treatments. Dr. Wakefield has numerous accolades and awards for her work benefiting patients across the country through her research, her teaching, and her leadership. We are extremely fortunate that she has taken the time today to sit down with us and discuss some of the most common women mental health topics. Thank you, Dr. Wakefield, and welcome to the Med Edit Podcast.
Hi, thanks for having me. I'm really excited to be here.
Awesome. Well, I'm super excited to have you here, especially today because we're talking about maternal mental health and specifically mood and anxiety disorders occurring during pregnancy and the postpartum period. Dr. Wakefield, tell us a little bit why this topic is of special interest to you as a psychiatrist and what led you to make this a priority in your practice?
Yeah, sure. I think it's, why is it of special interest to me? Really, because I think it is the most important thing that we can put our efforts to as a community and as a society. I got specifically interested in it. I was in child and adolescent psychiatry fellowship when I found out that I was pregnant with my first kiddo, and I had been on an infertility journey, and that was really exciting and scary, and wanted to do everything right and wanted to really understand. And so I wanted to take care of myself and know what I needed to do to create the most hospitable and healthy environment for this developing baby that I wanted so dearly. And then I also was doing examinations and evaluations for kiddos with mental health distress and talking to their mamas. And when I would take a pregnancy history for the mom and a developmental history on the kiddo and family history, I would realize, hey, all these moms had symptoms that were never treated. And so really focusing on perinatal anxiety and mood disorders became a primary prevention strategy for me for children's mental health distress. So I think it's really, really important to treat mom, and I have a special affinity for moms, and I really love working with moms. But I also think as a child psychiatrist and someone who's just interested in the wellness of our community and our society, that treating moms is the surest, quickest way to a healthy society, because I can treat one kiddo in a household. But if I treat mom, I'm like treating the entire household.
Right.
I love that. I love that way of looking at it. That's so important. It leaves lasting effects throughout the family, throughout the community. That's amazing. You know, your passion, your dedication to maternal mental health has always been inspiring. You were one of my attendings. I think you had just started when I started medical school. Actually, like my first year was your first year as an attending. And I always thought it was so amazing. And you've been the same way, steady, since the beginning of me knowing you. You've always been such a passionate advocate for women, for children. So we really are excited to talk to you more about some of these topics. With postpartum mood disorders being the most common complication of pregnancy, twice as common as gestational diabetes, why is it not talked about more freely?
Well, Well, I mean, we know there's a stigma. There's a stigma in mental health. There's a stigma for women thinking, well, if I get diagnosed with a disorder, does that mean I can't take care of my baby? Do I want to tell people what's going on with me? Will they think I'm incapable? Will they think something's wrong with me? I think that our science is way behind the times when you think of it. I know that anxiety and postpartum depression are low serotonergic conditions, that when estrogen goes down, serotonin goes down. And I know that that's a risk factor, but we can't measure serotonin. I can't show you that your serotonin level is low. I have to take a symptom history and tell you that's what I think is going on. And then I have to give you a medicine that will increase serotonin. And you just have to trust me that and I think it's part of what I actually love about our discipline is that it's totally reliant on this relationship that you have with this other person. But that has its drawbacks too, because you're just now meeting somebody. Am I going to tell you all of these things that I've been thinking and doing and saying and feeling? It would be so helpful to be able to draw a serotonin level or a dopamine level or a norepinephrine level and say, look, this level is low. We need to treat this. But because we don't have those biomarkers as a part of our clinical practice, it gets hard for everybody to know. And I think having a baby is hard, can be hard, right? We live in these kind of isolated communities. I think we're designed to live in tribes together and pass our baby off when we're having trouble breastfeeding to somebody else who's breastfeeding or somebody else who can take care of that baby while I take a nap. But now we're living in a society where we go home and we go to our four walls and we try to do it all ourselves and then put cute pictures of it on the internet. And if it doesn't look like that, we think that something's wrong instead of like, no, that's abnormal, is to go home by yourself and try to do this all on your own and then put cute pictures on the internet. That is the abnormal part.
Right.
But I think it's like the expectation that we've set for ourselves with magazines and, social media and all of these things. We think, I can't tell somebody that this is happening. And then the doctors don't have biomarkers. It makes us feel uncomfortable about how to treat this and how to diagnose it.
Yeah, I think that's really fascinating. And I honestly, even being a healthcare provider, I feel like we aren't necessarily well trained in that, at least coming out of medical school, our residencies and fellowships, unless you're doing something specifically your discipline. And it is really important because I think back to even when I started my career, and as female physicians, we all see this, we see a lot of females, right? And, as you know, stress and anxiety, like we talked about last episode, it presents with a lot of GI symptoms. And I didn't really appreciate that until I was practicing on my own about how many women that I would see and they'd be bringing their babies in with them. So, I mean, we're talking shortly after they deliver. And I don't even think that I was well trained until I had to make an effort to be like, are you sure this isn't a mood disorder that you're having GI symptoms? This is really a reflection of other things going on. And probably until I had my own children, honestly, I mean, really, really understood that. And I agree. I think it's something that even as healthcare providers, we don't get a lot of experience with, and we are frequent touch points for those patients, especially in that period. Like you said, they have their four walls and the only other people they might see is their doctor, right? And so I feel like that's an opportunity for us as well. Again, some more education experience would be really helpful.
I think that's exactly, me being postpartum right now. My baby's 8 weeks old and we don't have any family nearby. So definitely it's one of those things you sit there, you're in your four walls and you're like, okay, there's only so much talking to your own baby that you can really do with no one responding really back. But it's so important. I know in my practice that I've become 10 times better of a doctor by having children, by having gone through experiences. I now know to ask some moms to come in and see me, even if it's outside of that postpartum window, which postpartum lasts a very long time. We're always in that. If you have a baby, I feel like you're now always postpartum and you have symptoms and things that can last forever from it. And so I'm much more open to asking them questions, or when we're discussing even things like diabetes, asking how their new baby and their role and their sleep patterns and things like that are affecting that as well.
Absolutely. So just so we can clarify for everybody, what is the difference between, say, the baby blues and a true perinatal mood and anxiety disorder like postpartum depression or postpartum anxiety?
Yeah, I think it's a great question. And it also leads to the ambiguity in diagnosis for people. So, baby blues are a typical physiological response to a hormone shift postpartum. Everybody's hormones are shifting very quickly postpartum. And as I said, serotonin follows estrogen. And so you're having a pretty quick serotonin shift. And if your body habituates to that, like it'll last for 2 weeks or less, and then you will move on from it. But during that 2 weeks, you can feel overwhelmed, you can feel tired, you can feel emotional, you can just feel kind of down and like, I'm not eating correctly, I'm not sleeping correctly. Now, all of those symptoms can also be from having someone say, hey, take care of this other human life and not yours, and do it on your own. And so I think sometimes that gets a little convoluted too. That 80% of women, at least 80% of women, experience baby blues or those postpartum blues. So that's a really, really common just I think of it as like this physiologic hormonal shift that you're experiencing. And if you happen to not have it postpartum, I mean, go, like, I'm excited for you, but it's nothing that you did really. I mean, that's just how your body responds to that estrogen and that serotonin shift. When we think about postpartum anxiety and postpartum depression, it's almost that like I mean, I think you can most easily describe it as that baby blues period extended. It's like your serotonin doesn't rebound, like it doesn't come back up as your estrogen kind of normalizes. And so you're like, oh, I'm still having these symptoms. It's more than 2 weeks. Now it's 4 weeks. Now it's longer. I'm having these other symptoms. And it gets more classically able to be diagnosed. So I'm having you mentioned postpartum OCD earlier. It's something I see all the time, very misdiagnosed or underdiagnosed or just not recognized. But mom's having checking behaviors of baby all night long, right? Or mom's really checking on baby. Mom's worried mom won't let baby out of her sight. Now, our society rewards that kind of behavior, like, oh, good mom of you, that you're not going to let somebody else watch your kid. But actually, that's not a typical, like I said, we're designed to live in tribes. Our brains are designed to say, oh, safe person here, take my baby so I can take a nap. Our society is like, don't do that, do it all on your own. So it rewards some of these behaviors. So it can take a while before we actually know they're functionally impairing. But that's the difference, is they're functionally impairing. Baby blues, you might feel a little cruddy, you feel a little down, you're still getting up, you're still doing what you need to do, you're still taking care of baby, you're changing diapers, you're doing these other things. When you have a diagnosable condition, we always think about what that we have a manual that we use to diagnose things, and one of the criterion in there always is the level of functional impairment, so significant functional impairment. So we're really looking at what that level of functional impairment is associated with that condition. And many women don't outwardly show functional impairment, but it's more like they're not sleeping, they're having a lot of negative self-talk, they won't let anybody else watch their baby, they won't, separate from their baby, they're very, very nervous about that, or they're up all night doing different things. So it's really looking at the persistence of the symptoms, time-wise, and the functional impairment associated with those symptoms.
That's a really good way to look at it, because it's multiple aspects. It's not just what you maybe typically think of somebody who might be depressed and isn't getting out of bed and, neglecting baby, but it could be even overly tending to baby too much, having 3 monitors on them at one time and putting their hand on top of their chest and making sure they're breathing at all times. One of the interesting things about the postpartum OCD, which is why we kind of want to bring that one up, like you said, it's probably underdiagnosed. People don't really know about it. One of the things we were reading about and I've heard about is intrusive thoughts. Can you tell me a little bit more about the intrusive thoughts associated with OCD? What's normal? What's more OCD behaviors? And then in a minute, I know Cari wants to ask you about the, stuff, the interesting stuff that, that we hear in the news, like the psychosis and stuff. Like, how do we show that, what those intrusive thoughts, where do they go in what category?
Well, and I would say what's even more interesting is that intrusive thoughts are actually part of postpartum, that they can be quite typical. And so but they can be quite scary. And when they're scary to you, I actually feel much better about them. Like if you're having intrusive thoughts about worrying that you're going to hurt your baby, it's what we call being ego dystonic. If it's ego dystonic, it feels like, I don't want to feel like that. That feels weird. That feels scary. And that to me, I'm like, we're good. We're okay. You're okay. I mean, you need treatment. We need to help you potentially if it's not just a typical thought and it's an OCD thought, but it's not, it doesn't worry me for being dangerous to baby. Ecosyntonic is where you can't separate it. Like it really does seem like something you want to do. And that usually is associated with postpartum psychosis. So we can get into that in a little while. But many, many moms, it's actually quite typical for a mom to have a scary thought that I'm going to do something to hurt my baby, which is really hard to hear for everybody. But if you've been a mom, you might have had this thought before. Like, what if the stroller rolls in the street? What if I push the stroller too hard and it rolls in the street? What if I'm on this dock and I drop my baby over the side and they drown? Like those are anxious thoughts associated with being responsible for another being's life. And
Absolutely.
it's like a worry that you are going to be, that you're not going to be vigilant enough to save them, which is very, very different from I want to hurt my baby. It's actually the polar opposite of that. It's I'm scared that I'm not capable of doing this job. And so am I okay to do it? Like I want to do everything I can. So when I'm talking to, and so in OCD, it's just like hyper fixation and a lot of worry or compulsions that we do to control that thought. So I give an example of when I was postpartum with my first child. We lived in Louisiana, and we had a big drop off. We lived on like a hill, and we had a big drop off of our deck. And I would walk on that deck with the baby outside because he loved being outside. He would immediately be quiet and look around at the sky outside. So we spent a lot of time outside. And I would get so scared walking to the edge of the deck. I mean, it had a railing on it. I would get so scared walking to the edge of the deck. What if I trip? What if I throw him over? What if, all of these kind of what if thoughts. So what did I do? I didn't walk to that side of the deck. I stayed on the other side of the deck. So I did something that was protective because I was scared something was going to happen. I didn't want that to happen. I wanted it not to happen. Now that is a fairly typical postpartum kind of intrusive thought that women get. And as long as you can say, you're okay, that will go away. It will get better. This is overwhelming. It's a lot to handle. Then it's okay. What we see in OCD is that those thoughts don't go away. And then I modify all of the things I do through compulsions or other behaviors to try to make that thought go away. So I say, oh, well, I'm only going to walk in this one pattern back and forth, and I have to walk this many times to make it okay. So it's the OCD is kind of those intrusive thoughts that are more typical on steroids. And then you really modify your behavior and create a functional impairment that can lead to additional things as well. So I treated a mom who had postpartum OCD, and she was up, she would check baby's temperature, 10 to 12 times a night. And because she was so worried baby would have a fever. And she didn't sleep for many days. And then she started hearing the toys go off, and she started hearing these other things. And so she told somebody this, and they told her, you have postpartum psychosis. Well, anytime you're perceiving things that aren't actually happening, we call that psychosis. But whether it's a primary psychotic disorder or whether it's a symptom of something else like sleeplessness, are two different things. So her diagnosis was not postpartum psychosis. Her diagnosis was postpartum OCD. And she was so delirious that we needed to treat that so that she could better, sleep better. And then the psychosis or the psychotic symptoms would go away. As opposed to someone who has a postpartum psychosis where they are starting to internalize delusional schema. They're thinking, someone's out to get us. If I go over to that edge of the railing, someone's going to be there and they're going to try to take my baby. Or if more paranoid. I mean, the first stuff is a little paranoid too, but more paranoid things. Or I treated a woman with postpartum psychosis who had these worries that when the baby cried, the people who were going to be after them could hear. That's what would attract them to the baby to find out that they were there. And so that becomes very dangerous. Because if you're worried that babies are going to cry. And if you're worried that baby's crying is going to expose you to some danger, you might be at more risk of harming that baby, even unintentionally, smothering that baby, covering the baby up, doing those things, leaving the baby somewhere. And so postpartum psychosis is actually very dangerous to both mom and baby, and is an emergency. But delirium associated with sleeplessness, associated with OCD, needs treatment. It absolutely needs treatment, but it's not dangerous to baby. And when we separate baby from mom, when mom says, I'm having these worries about hurting my baby, I'm having these, and I say, what do you do? And she goes, I leave, I call somebody else. I don't want to do that. If I separate baby from mom when I don't need to do that, it tells mom she's incapable and she's dangerous. And so it is really important to try to get to the heart of, is this primary psychosis, which is an emergency, or is this an anxious related behavior, which I need to treat mom and help normalize some of these feelings?
That makes so much sense. And I think that's so helpful to show what is the normal postpartum intrusive thoughts, the escalation to where we actually have a pathology associated with it, and then the psychosis standpoint. Because really breaking it down and understanding and normalizing some of those things is great. And thank you for sharing your story, with your baby at home. I mean, I for sure have had that with both of my kids. I'm just an anxious person in general, just personality type. But I definitely, like, when I walk on my stairs, I'll like clutch the baby a little closer, being like, okay, what if I fell? And I mean, I've gone up and down my stairs 100 times and there's railings and everything. It's not unsafe, but I've thought, I don't want to fall. I've got to hold him a little bit extra tighter. But like you said, if I now never went upstairs anymore, I never used the stairs, I avoided the stairs, I kept all his stuff downstairs, that's where we come into more of like a pathologic response. So I think it is something we have to be a little more open talking about. I brought that up with my hairdresser because she was postpartum. We were talking about it and she's like, oh my gosh, I've had those too. And so we are kind of discussing what's normal and what's not. And it's nice. We don't live in tribes like we talked about. So it is nice to have these conversations openly. And that was the whole point of the podcast, right? So we can have some of these conversations and make people say, hey, that's happened to me too. That's okay. That's normal. Dr. Wakefield said that is still in the normal category. It will get better with time.
Yeah, absolutely. And, we hear about some of these sensationalized stories, on the news, for example. And of course, those tend to be outliers and extremes. But in general, how common is something like postpartum psychosis? And is there someone, from before they're pregnant that's more likely to develop that, in the postpartum period?
Yeah, it's a great question. It depends on how you define postpartum psychosis. And I think, like many things that we study, that becomes the hard part. So when you put more things in the category, then it seems more common. And like I said, there are women who get postpartum psychosis diagnoses because they had a psychotic symptom, but it was related to something else that wasn't a primary psychotic disorder. And when you look at that, it's actually like pretty common. But I'm talking about like thinking I'm hearing the baby crying from the other room, right? Like hearing this toy go off that didn't go off. Like when you're thinking about any psychotic symptom, those are actually pretty common because we're sleep deprived, we're anxious, we're overinterpreting signals, all of those different things.
Right.
When we're talking about, and so if you just search, I did it because I knew you were going to ask me this question. I just searched on Google what would come up. And literally it was a range of 0.6 in 10,000 to 1 in 7. And I was like, this is so ridiculous. Because it really, I'm just thinking if you have listeners or you yourself, like look this up, you're like, oh my gosh, 1 in 7 people has a primary psychotic disorder where they want to kill their baby. No, they do not. And so it really depends on how you define it. It's pretty rare. I mean, it's really rare, but for women, but it is an emergency. And it is something that we should tell women can happen because it can be the first time that they've ever had a significant symptom. Usually, usually there's some kind of a history. One of the more common illnesses or diagnoses that has a higher rate of postpartum psychosis is bipolar disorder. So bipolar disorder is the disorder that I'm thinking I need to tell you a lot about what to look for in the postpartum period. And I do not want to stop your medicines. And I want you to keep taking your medicine. Because for women who stop taking their medicine who are bipolar, who have bipolar disorder, there's been an 85 to 90% relapse rate.
Wow.
If they keep taking their medicine, there's still like a 10 to 20% relapse rate. So bipolar disorder to me is one of the most dangerous conditions during pregnancy and postpartum period. I have helped many, many women transition through motherhood with a bipolar diagnosis, and we have done that successfully. I've had women who have gotten psychotic in the postpartum period, and we gave them anticipatory guidance before that, and we were able to talk with their partners, and they were able to successfully have a baby and And we navigated that several times without hospitalization, which is fantastic. But if you need to go to the hospital, we want you to go to the hospital. So I don't want anybody to go away from here saying, oh, if I have this diagnosis that I shouldn't have babies or can't have babies or couldn't be postpartum. But it does require a lot more discussion and planning, and talk about sleep and those postpartum period and things like that. But so bipolar disorder is the one that worries me the most. When we have women who have like a schizophrenia diagnosis, they might get psychotic in the postpartum period, but it's not typically a postpartum psychosis like related to just the baby. It's typically related to their primary illness.
Sure.
So that kind of confounds it a little bit. But both of those diagnoses, bipolar disorder and schizophrenia, are very rare diagnoses. I mean, 1% of the population each. And so very, very rare diagnoses, but those are the ones that worry me the most. There are women that we think have an isolated postpartum psychosis with a history of postpartum depression. And that's all they get. Like once that's resolved, they don't have additional symptoms. And they don't have a bipolar diagnosis long-term, and they don't have a risk of mania. It's really hard to prove the negative is what I'll say. So it worries me if someone gets postpartum psychosis. We have to talk a lot about when to stop meds and how to stop them and if we should stop them, and really do a risk analysis with that mama to say, how bad did it get? How insightful were you? I treated a mom recently who was very insightful, even in the height of the psychosis. I mean, I think somebody's coming after us. These are signals that, very hyper religious, hyper paranoid, psychotic, felt like the baby was creating a danger, but very insightful, like sought help. And like, that's fantastic, right? Like if you can stay insightful through the episode and we can get you treatment, and you were willing, she came into the hospital, we were able to treat her. She was willing to stay. I mean, I was like, I don't understand why you're so insightful throughout this process. But that's a lower risk than for someone who it came on very quickly and they weren't insightful and we were having really hard time getting them into treatment. Then I would say, let's stay on this medicine.
Sure. And we've done a really good job of defining a lot of these things, which is going to be very helpful. So if there is a woman who feels like they may be suffering from a perinatal mood or anxiety disorder, like we discussed, are there anything that they can do to help prevent it, maybe potentially, or, head it off early?
Yeah, I think there is, and it depends. So I think often of there's a book we read in psychiatry about psychopharmacology by Stephen Stahl. And one of my favorite things in there is the comparison of the truck and the bridge. And so I don't know, Dr. Gray, if you remember me talking about this a long, long time ago, but I think of everything, all illnesses, not psychiatric illnesses, but all illnesses as the kind of the juxtaposition or our truck and our bridge. So can our bridge support our truck? Our truck is really like all that stuff that life piles in to the back of our truck. And our bridge is what we came to this world with genetically, and kind of early brain learning and how our brain structure is developed, which by the by depends on things like how much of a sing-song voice our mom used with us in early postpartum period. So, all of those kinds of things. So our bridge is stuff that really we can't life out of. I mean, maybe you can do some really awesome therapy out of it, but like you can't life out of. And then the truck is all the stuff that goes in you're dealing with. I mean, trauma or stress, grief, all of these different things that kind of happen to you over time. So first I'll say it depends if it's a truck or a bridge problem, how much you can prevent it. Sure. There's some great data. It's really primarily focused on women of lower socioeconomic status who have a risk of postpartum depression of 1 in 3, where the risk of postpartum depression, now total postpartum, what we call PMADs, postpartum mood and anxiety disorders, like 1 in 4, 1 in 5 for women, but depression specifically is about 1 in 7 for all women. So solely doing an educational based program prior to delivery, which teaches you to not do things like try to make your house perfect. Try to do everything to, for everybody else. Reach out to somebody if you need something. It's totally just educational, building community, all of that. It reduces postpartum depression for those women who are 1 in 3 to 1 in 7.
Oh, wow.
That's it. No meds, no therapy, like a 15-minute with every appointment educational strategy. That's it. And so there are things, I think, like normalizing that you need help when you bring a new human into the world, and doing those things can be really helpful. I remember my OB with my very first kiddo said, hey, right before I delivered, she said, okay, so if you feel like just kidding, like after he's born, just kidding, didn't really want this is too much for me. Can we put him back in? I'd like to do this later. I would like to choose a different time. All of that's normal. She said, if you feel like I want to kill him or myself, call me immediately. So I mean, just that, just someone telling me it was going to be normal to be like, I don't know. Was this it?
Is this what I signed up for?
Is this what I signed up for? I tell a story often about a colleague of mine, a dear friend of mine, who also had an infertility journey, and we were kind of going through that at the same time. And she got pregnant before I did and delivered before I got pregnant. And she called me one day early after delivery, and she said, they lied to us. They lied to us. This is not what we wanted. She has 3 kids, happy as a clam, like,
Right.
did it again, all of that. But it's just like, it was so helpful for people to just say, like, this is harder than I thought it was going to be. It's harder than I put in my head it was going to be. And is this what I wanted? And for someone to say, that's a pretty normal thought, and you're going to be okay. So I think that's a prevention strategy in and of itself. And having like a group of people you can talk to and you feel comfortable talking to about that. And then really taking as good a care of yourself as you possibly can, and knowing that self-care for moms is caring for your babies.
Sure.
One of the things that I found so much in my child fellowship was these mamas cared deeply for their babies. They would move mountains to bring their babies to treatment, but they had never treated one of their symptoms. And I would look at them and I would say, Mama, I can't get this kiddo better if you're not better.
Yeah.
I can't.
sense.
Like they are modeling off of you all day long. So you must care for yourself. That is care for your family and for your baby. So I think saying that to moms, validating that they really need to do that, and then helping them do that. Like, does that mean therapy? Does it mean walks in the park? Does it mean changing jobs? Does it mean medicine? Like, what does it mean? And whatever that is what we do, because getting mom better and having a healthy mom is the most important thing for baby.
Absolutely. And I love that there's so many options we talked about that are not necessarily medication, because I think that's what scares a lot of people, especially in that time period when we're talking about things like breastfeeding. It scares a lot of moms of what impact that can have on their babies. Now, say that, you've done all those things, it still happens. What medication options, like we talked about, are commonly used, we would say, in women in that period?
Yeah, absolutely. I think thank you for bringing this up. So many people are scared of medicine. We do so many things that are much more dangerous to baby than take a medicine to treat mom to get her healthier.
Sure.
And that to me is another part of the stigma. Like,
Mhm.
Mom, just tough it out. Mom, change everything that you eat and drink and walk and talk and, however, do
Yeah.
all these different things so that you can care for your baby, but like, don't take care of yourself, which is ludicrous. Like, taking care of yourself is the primary thing you do to grow a healthy baby and take care of baby. And if that includes medicine, it includes medicine. There's
Right.
almost nothing that I'm going to say it's more important for you to suffer than it is to take this medicine. Actually, there is nothing our studies are very clear on that. Treating mom is the most important thing to do, no matter the medicine. Now we might change the exact medicine,
Right.
but medicine in general should not be a barrier to treatment, because it's much more important that mom get well than to prevent baby to be exposed from that medicine, pregnant or breastfeeding. So what are some common things when we think about depression and anxiety? First, we really want to think about, like I said, all these other things that we talked about: therapy, group interventions, socialization. Postpartum Support International has online groups about everything. They're free access. You can try to find your tribe there, because they have so many different options. So I think that's really great. You can try to find people who've had a more similar experience to you. So those are really, really important. But if you are going to take a medicine, many common medicines are called selective serotonin reuptake inhibitors. And they're the things that you probably heard about: Prozac, Zoloft, or sertraline, fluoxetine, whatever. If you want to use the generic name or the trade name. I don't know if we have embargoes on saying trade names here, but those are the ones that people often hear.
Right.
Right.
And we use those. Like I said, it is more important to get mom well than it is to worry about that exposure to baby. In breastfeeding, I have ones that I love more than others because we think about what we call the theoretical infant dose anytime you're treating a mama about what's going to come in her breast milk to the baby. And we'd like that theoretical infant dose to be 10 or less. So that'd be great. So there's an SSRI that has a theoretical infant dose of 0.2. So if I get to choose, I want to choose that one. Right. But here's
Makes
what
sense.
I'm not ever, ever, ever going to do. If mom comes and tells me this is the medicine that I've done well on, and when I'm off of it, I do poorly, guess what she's going back on? She's going back on the medicine that she did well on, because what's more important than anything is getting mom well. And I would say, hey, we're going to watch baby. And if baby has some irritability or something like that, then we can see if it correlates with the medicine. But these SSRIs are safe. They are not going to cause long-term problems. We have pretty good data that there's no, there might be, if you have been on an SSRI prior to delivery and that baby is never going to breastfeed, and so they're kind of having an SSRI withdrawal right around delivery, then they can have a little bit of an irritability syndrome. We've seen that. We have. But we also know that that doesn't translate to anything in the future. Like, that doesn't say they're going to have irritability forever. It doesn't actually. We know that if mom was anxious and depressed in pregnancy, they're more likely to be irritable, have behavioral disturbance, have many other anxiety issues, all of those things. And so treating mom is much more important than not treating mom. But because we can quantify pretty immediately that irritability syndrome associated with, post-delivery, then people are like, I don't want my baby to have that. But it doesn't mean anything bad. And there are babies who are irritable post-delivery who were never exposed to an SSRI.
Oh, those are mine, my fussy ones.
Yeah. And so I think, it's for me, it's always talking to mom about risk. People always say, like, risk benefit. I'm like, we know what the benefit is. The benefit is getting better, or the benefit is not exposing baby to medicine. I'm talking about risk. Like, let's really talk about, if we're exposing baby to illness, we know that causes long-term neurodevelopmental consequences. We know that. There's no question. And it causes bonding problems, and it causes long-term problems for mom, right? To feel like I'm not confident in my ability to be a mother here. So that the risk of not treating is that. And then we talk about the risk of treating, and I'm like, here are the things that might happen, but they might happen anyway.
Right.
That's a really good point. Thank you for specifically talking about the medications too, because that is one thing that we really want to address the stigma on, is medications are okay. And in later episodes, we'll talk specifically about SSRIs and probably dispel some of those lovely myths about them in general, which that's just something that needs to be done. But that's a really great point to bring up.
Absolutely.
So sometimes it can be hard for family members or friends to support those that are, going through this postpartum period. In those first few weeks, people have those meal trains and everybody's checking on you, and you get phone calls and texts nonstop. And then all of a sudden it kind of fizzles out and you're just there with baby, right? Maybe you've gone back to work already, or maybe you haven't yet. Do you have any advice for the partners of these mothers with postpartum depression or anxiety, or just in that postpartum period? How can loved ones support someone who may be struggling?
Yeah, I think it's a really great question. And it is really personal, right? Like, people need different things. It can be really hard to communicate. One of the most helpful things my husband said to me in my postpartum periods was like, I'm here to help take care of you so that you can take care of baby. And I feel like that really felt good. But also sometimes I was like, can you also take care of baby so that I can go sleep? And he would. I'm not saying he wouldn't, but it's just, I had to kind of ask for that, because I naturally would go grab the baby. Like, we have some pretty interesting studies about fathers in the first year postpartum, that they tend to defer a lot to mom. Well, of course they did. Like, mom carried this baby for a really long time and then delivered this baby. Like, the father kind of feels separated from the baby a little bit and feels like they've been supporting mom this whole time and not really connecting in the same way with the baby. Now, after a year old, when the baby can kind of toddle around and smiles at you and interacts, dads get really involved. And so it's not oh, something's wrong with the dad, that they're not getting as involved or don't feel as attached in the first year. It's just kind of a normal, or can be a normal. It's not normal for, it's not typical for everybody, but it can be really a typical thing. And so dads or partners sometimes are really focused on the person who had the baby and saying, oh, I'm going to let you take care of this baby and I'm going to support you, which I think is really lovely and maybe what that person needs, but they also may need to, like, get away from the baby. And so I think really what our systems can do is ask us what we need, offer us multiple different things, and give us time away, and then not make us feel guilty about it. Say like, this has consumed. I mean, I think about just the idea of someone staying and me walking around the block by myself, like not pushing a stroller for a hot second, not feeling like I have to attend to someone else's needs 24 hours a day, and just having a little bit of time separation from that can be really, really helpful, to go back and feel energized to do it again. And then scheduling things, there's, especially when we're talking about sleep, if you have a baby who, I think it's much more important if you have a baby who's more colicky or is not sleeping well through the night, to take shifts and actually set that up, if that's going to be helpful to you. I'll tell you, like my 3 personal babies, they soothed pretty quickly to at night, in the middle of the night, to nursing. And so all I needed to do was to be able to go, get them quickly to nurse them, and then put them back. And that was fine. I mean, that worked for me. And if somebody was going to rile them up, and, I didn't
Sure.
need to do that. But if they were crying all night, I was like, I've already nursed them. I've already done everything I can do, and I don't have anything else to give. Then I need to ask you to take them now. Like, can you take them and walk them around? Can you take them out of this room? I'm going to go in another room. I need a
I
little
did this
bit.
at 4 a.m.
Yeah.
today. I literally did this. I was like, but your point is that you're saying before, which is I really want that like soundbite to be saved so that moms can go share it with their partners, is that they have to ask, and it's okay to ask, and their partners need to be able to say, yes, I can do that, without making them feel guilty later, without saying, well, how long are you going to be gone? Like, you've done this, 2 times this week already, or something like that, right? We need to make sure it doesn't feel like a tit for tat situation, that this is something that we're supporting them through in a big way.
Yeah.
I mean,
And I think most
yeah.
of the time that comes from anxiety in the partner. Like, I trust you to do this. I think you know how to do this. I'm worried I don't know how to do it in the same way as you. And when you
Interesting.
think like, we've been doing it for 9 months or almost 10 months, and then, and, a lot at the very beginning. And so they're like, I don't want to mess it up. But what that feels like is like, it's all me. It's only me, and you
Right.
can't handle this. And so I think also being like, I trust you. Like, I trust you to do this. I need some space, and I trust you. Like, you are a great partner, and you are a great parent. And so trying one of, I'll probably bring this up every time we talk about anything, but one of the people that I love following, her name is Cy Wakeman, and she talks about assuming positive intent in everybody, and how whether they have positive intent in what they did or not, it helps you feel better about it. And so you just think, like, when they ask this question, instead of thinking, oh my gosh, they think I have to do everything, they won't do anything, to say, oh, they must feel anxious about this. Like, it's not about them not wanting me to go take care of myself. It's about them not feeling like they're capable of doing it.
Absolutely. And those are all such great recommendations. I feel like honestly that could apply to lifelong parenting. Let's be honest. I mean, like, parents in general, we need breaks like forever. And so I think that it's great during the postpartum period, but it's just great advice in general to parenting is, being able to take away so you can step away so you can come back re-energized. I kind of one last question that we have, just what advice do you have for moms that are making that transition back to work when they're having to leave baby, at home, or like you mentioned, with somebody else or in a daycare? Because that's really a tough time, for both parents, but especially for moms. And we kind of wanted to leave our listeners with some ideas of how they can make that transition.
Yeah, I first want to validate, if it doesn't feel tough for you, that's okay too. If you're like, cool, I get to leave this kid and go see adults, like, that's all right too. So if it doesn't feel that hard and it feels kind of great, fantastic. But it did, I mean, you got to think that you've been with this being, I mean, in the same body for a while, and then in the same room for a while, and then in the same house for a while. And so separating into 2 different physical locations and leaving them with someone to care for can be quite anxiety provoking, and just feel like a grief process. Like, you feel grief is about loss, right? Like, I'm feeling like I'm losing something here. So to really acknowledge that, and to take care of yourself, and to validate it and say, this is part of it. It doesn't mean, I think a lot of times with grief processes, or if we're feeling like, oh, I'm sad about this, that it means what we're doing is bad. Instead of just saying like, no, I can be sad about one thing and being excited about another. or we tell ourselves that it means more than it does. Like if I'm sad about this, that means I shouldn't work. We do, we should on ourselves a lot. Like if I'm sad about this, it means I shouldn't do this, or I should do this. And if you are super sad and you have the ability to change what you're doing at work and you want to go be with the baby, I mean, go be with the baby. So listen to yourself. But I also think like, don't overinterpret what those feelings are. Like it's normal and typical to feel some loss when you go back to work. It doesn't mean that going back to work is bad. Like you went to work in the first place for a reason. There was something that excited you about that. There was some identity that you had there. And so go back and try that out. Can you achieve that again? Or have your goals changed? Because that could happen too. And you want to revise that. And then I would say like, ask for what you need for, if you are feeling like, I mean, if you're breastfeeding, you may need to ask for the time to breastfeed, a place to breastfeed. If you need, I mean, now they have all these new fancy pumps that are amazing that you can like breastfeed anywhere, anytime, right. I feel like, but still you may be a person like I had to listen to sounds of my baby crying to have letdown. And so I can't just like do that in the middle of a patient visit. And I successfully breastfed my kids for like longer than 12 months for all of them. And it was great, but I had to like train myself at how to do it. I had to disengage from work for at least a couple of minutes. I mean, 1 to 3 minutes or something so that I could get my brain in a place to breastfeed or to pump. I hated pumping. I hated it. And I did it 3 times for a lot of months. And so I would give myself rewards for pumping. I'm a behavioral specialist over here. So I would only allow myself to look at social media when I was pumping, and I would like tie these things. So I needed some time away, the 15 or 20 minutes. And so I think you got to ask for those things, and that's different for everybody. Like you're not going to know, it's going to be iterative and like trial and error to try to figure out what works for you. And that's okay too, but get as much input as you can from different people around you who have done it. Or might have done it in the same environment that you've done it, which can be hard. Some of us are in environments where there aren't many women who have done it before us there. But having that, I mean, I remember I put a sign on my door and I was just like, hey, I'm not available right now, call me or text me if you need me, but don't walk in. And I was able to do that.
And I think that's a good point too. Like even with saying things like protecting your pumping time and stuff like that. I've had I've had to have those conversations with even my employers before and be like, okay, this is protected legally. And so just as a side note, in our show notes, we'll also include some information about your federally protected pumping time for women that a lot of women don't know about, like where it can't be a bathroom and things like that. So we did want to make sure that we included that for them as well.
Absolutely. That's great. And such a great episode today. Thank you so much for being on, Dr. Wakefield. We always love talking to you, and it's transformative and informative. And we know our listeners will undoubtedly benefit from your knowledge today.
So that's all for today's episode. Thank you guys for listening. Please like, subscribe, and share the episode. Let us know what topics you're interested in through our Instagram, and stay tuned for our next episode.